Hello, welcome to University Hospital's Department of Medicine Grand Round Series. Today we are pleased to have Dr. Rana Hejal speak with us about sepsis. Dr. Hejal hails initially from the American University of Beirut in Lebanon. She completed her residency training and fellowship in Cleveland and has been a Northeast Ohio mainstay since then. She was program director of our Pulmonary and Critical Care Fellowship until 2013, when she transitioned to critical care in the community at Summa Health. She returned back to UH in 2016, tasked with restructuring a growing ICU at Ahuja. She is currently a clinical associate professor of medicine and is the medical director of the MICU here at UH Maine. For the house staff, Dr. Hejal represents a bastion of critical care knowledge and a true teaching attending in every sense of the word. It is no shock that she will be leading UH's charge against sepsis in the near future. Please join me in welcoming Dr. Hejal to the UH Grand Round Series.
You're too kind. Thank you so much. I really appreciate coming back. Haven't been here on this podium for 2 years now, or 3 years. I miss it, I have to admit, and I really appreciate the invitation. Sepsis 2020, as 2020 by itself is a great terminology. It's hard to tell whether it's a Vision 2020 or the year 2020 or 20 out of 20 with a 100% scoring system. So keeping it vague is a good idea. I have zero disclosures. After all, I'm a simple teacher. The outline of this talk will go over the epidemiology, pathophysiology, very little about pathophysiology, definition changes over time, and we'll spend a lot of time on the Surviving Sepsis campaign with the key clinical trials that guided our management, and then spend some time on the UH initiative. Sepsis is a big thing. It affects more than a 1.5 million people in the United States, and is approximately responsible for more than 250,000 deaths per year. Across the world, globally, it's far bigger of a problem, and it has been estimated that by 2020, the number of patients with sepsis is going to be in excess of 1 billion patients at a time. Septic shock, when you look at it, leads the causes of shock in the world of critical care medicine. If you remember, this is for the house staff really, if you remember your 4 different categories, distributive, where sepsis comes in it, or distributive that's non-septic, 62% of the people are in septic shock. Hypovolemic comes next, obstructive comes later, and cardiogenic and hypovolemic shock takes care of them. So out of all of these, cardiology takes care of this, and all of this the ICU team takes care of, for those of you who are interested in fellowships. The focus has to change a little bit. The projection over time, like, you know, as the incidence increases, it has been keeping on increasing, and this is a relatively older slide. By 2019, it's still linearly increasing. And at that time of this study, when you look at the older definition where you have sepsis, severe sepsis, and septic shock, the mortality rates are much higher in the shock patients in comparison to just simple sepsis. So when you read literature, they will tell you, well, it's anywhere between 20 and 50%. It depends on the patient population they're looking at, where the patients in shock are still dying at a rate of about 50% or so. Derek Angus from Pittsburgh is the leader at epidemiology in this field, and perhaps the management as it goes about, and their work has led to the new definitions of sepsis, has projected that this line keeps on increasing way out of proportion to the population increase. And that's something that we have to really pay attention to as time goes by. Pregnancies are dropping, neonatal deaths are dropping, yet sepsis keeps on the rise. As the aging population increases, some people get admitted to the hospital with osteoarthritis, and they are on the rise as well, but the heart doctors have done a great job in heart failure, and it's on the drop. And that's projection from 2005 to 2014. Sepsis admissions keep on increasing. If you look at where these people are coming from, men and women are equal. Average age is in the upper 60s, so it's an aging population, and they spend about 9 days in the hospital. Where do they come from? Usually they come to the hospital from their home, the bulk of them, but unfortunately when they leave, they don't leave home. About 20% of them get dispersed either in nursing home or die in the hospital. That seems to correlate with multi-organ failure as well as with the aging group. Here, I ignored the neonatology part because there's also a higher peak in that age group as well. As technology improved, as transplant world improved, as treatment for cancer improved, there have been newer organisms responsible for the sepsis, where gram-negatives and gram-positive are on the rise. We rarely used to think of fungal disease. Now we have to think about it, and also viruses, but the viruses are not really on this slide. Multi-drug resistant organisms, where the lead are becoming more, and the antibiotic development is not as quick as the development of the the resistant organisms. They are, I guess, smarter than us. Bulk of the infections come from the respiratory system as well as the abdominal cavity. As a skeptic, you look at mortality comparisons, and this is published in the CDC 2014. The number of deaths annually from sepsis far exceeds the myocardial infarction world, lung cancer, colon cancer, breast cancer. But the attention is always here, and we ignore here. Food for thought. From a pathogenesis standpoint, it's very complicated, and I'm far from being a cellular person or a basic scientist. I'm a gross organ person. The nidal infection has to be there, whether it's related to an abscess, pneumonia, whatever it is. There's an organism that's responsible for it. It secretes a certain endotoxin that will destroy some structure, and it will focus on, go to the plasma, go to the monocytes and macrophages and endothelial cells, and a bunch of chaotic chemicals, I would say, or bizarre proteins will do their thing. And you can divide them into inflammatory versus and anti-inflammatory, and they go in a word of battle, causing a certain cellular dysfunction. Far from being capable of understanding it, but I think there's a lot of research in that area for whoever's interested for it. For me, as the bacteria endotoxin is present, you end up with a massive cytokine release. Whoever wins the battle ends up destroying several organs that goes from a central nervous system dysfunction to a hepatic dysfunction to a kidney problem to a vascular problem, and you end up with a hemodynamic collapse. And all of this will feed into respiratory failure, renal failure, disseminated intravascular coagulation, as well as coagulopathy. We see this at the bedside, and we see this a lot. If we sit back and try to figure out what's the best definition, we were all chaotic in our thinking until 1991 when SIRS became something. There was a meeting in the Americas. Roger Bone was responsible for that definition. He identified all the elements of SIRS that we'll go about later on. In 10 years' time, nothing happened until Manny Rivers said, okay, you can talk about sepsis all that you want, you can find SIRS all what you want, but you have to manage it based on a certain goal that you want to achieve at the bedside. From there on, Surviving Sepsis campaign was created as a body from Society of Critical Care Medicine and ended up adopting the Manny-Rivers approach to management of sepsis because it was associated with significant improvement in mortality. Thereafter, there were several other guidelines that came about. They were just a modification of this or that. They didn't really make any impact until the 3 trials that challenged Manny-Rivers' trial, and then CMS decided to adopt these, as well as a new guideline that came from Society of Critical Care Medicine, and lastly, the scientific people in the group, mainly the epidemiologists, said enough is enough. Sepsis is very nonspecific. SIRS is very nonspecific. Let's go ahead and look at our data and change our definition, and that's where Sepsis 3 came about. Though it came about in 2016, but it really got published later on and was adopted mainly last year. For the gray-headed people, this is what we went through from 1991 until recently. It was believed that sepsis is a spectrum. You start with a simple sepsis, you tend to miss it, or you tend to have some abnormality in the host defenses against it, and if you miss it all the way, you end up with a septic shock. And if one ends with a septic shock, there is a certain degree of multi-organ dysfunction, and if it goes to multi-system organ failure, death is imminent, and that's that. The document that came challenging this came from Sepsis 3, and it was published in JAMA, and I believe all of you have read it at this point in time. It came with a consensus statement from North America as well as Europe. I believe Japan was part of it as well, but I'm not really certain. The definition came as sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Shock, in particular, is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. This is great, but how would I define this as a clinician? As a clinician, it's a different story. How do we recognize sepsis, which came as, I think it's the same time that came about writing about this. The way they did it was to collect all patients who have sepsis across the institutions that were carried, and had divided patients into where they were in the ICU versus they were outside the ICU, and they looked at these huge numbers. And they compared different parameters, like the SIRS criteria in comparison to the SOFA, which is the Sequential Organ Function Assessment Tool, versus the Logaritmic Organ Dysfunction Score, LODS, which is predominantly used in Europe rather than here. And so what, like how many patients with sepsis are we missing? And it looks like SIRS did very poorly, because you missed a big chunk of patients if you were to use SIRS alone. And it's not only in the ICU, but also outside the ICU you missed it. Both SOFA and LODS did very well for both groups. So it was reasonable to say, okay, we have to move about. Just a reminder of what SOFA is. It's 6 organs that you go over, and you grade them from 0 to 4. Anything above 2 is considered drastically abnormal. It's like you have to compute a lot. So on the floors, it's practically impossible. So they looked at what would be an equivalent to that, and they picked from it, after looking at the 21 variables that they had in sepsis 2, it seems the 3 that were pretty important were restore rate, blood pressure, and altered mental status. For the documentation, it's encephalopathy. But the altered mental status can go from lethargy all the way to coma. So it's kind of truly a big spectrum of what we're talking about. So the clinical identification of these people outside the ICU, one has to know that they have a presumed active infection and have to be identified by Q-SOFA based on all of these. In the ICU with suspected or presumed infection, the people who are likely to have poor outcome are the ones who have a SOFA score that's greater than 2. Septic shock is identified by people who, with adequate resuscitation, are still in need of pressors to maintain a MAP above 65, and their lactic acid level is greater than 2. Do we agree now? How do we identify people with sepsis? Yes? No? Maybe? Clear? Clear. Management. We're sitting at the bedside. There are several steps that you have to go over in order to manage somebody with sepsis, defining them whether they are sepsis or septic shock. And by the way, the severe sepsis is gone. It's either sepsis or septic shock. And the reason was it was very hard for clinicians to separate the two. They're pretty much the same. But anyway, initial resuscitation leads. Infection issues is very crucial. One has to diagnose the infection, prevent it if they can, use the appropriate antibiotic therapy, and have a good source control. Hemodynamic support, adjunctive therapy, and supportive measure come later. But the first three are crucial. Initial resuscitation. It's protocolized quantitative resuscitation of patients with sepsis, induced tissue hyperperfusion. The goals are, initially it was within the first 6 hours, but as of now, it's we're decreasing that time interval to about 3 hours or so. During the Manny-Rivers time, which was adopted all the way until 2015, we wanted to have a central venous pressure that is greater than 8 to 12 millimeters. We always agreed on the MAP. Urine output has to be greater than 0.5, and if you were to have a central line, particularly when you have a central venous access, you want to have your mixed venous O2 or central venous O2 greater than 70 and 65% respectively. Those who have elevated lactates, you need to follow them until it normalizes. I don't want to bother you with Manny-Rivers trial, but this was in the ER in Detroit. You bring patients in, identify their SIRS criteria, decide whether they are septic or not, put them in early goal-directed therapy or not. And their early directed goal therapy is to maintain these parameters on them. And if they did not complete them in 6 hours, they bring them in. But this is the continuation of the algorithm, how they decide on hospital admissions and where they would put them. They start with fluids, vasoactive therapy, transfusion if hematocrit was less than 30, and mixed venous O2 less than 70. They will add an inotropic agent once they correct their hemoglobin. Outcome, all patients. People who went under the standard protocol had almost half of them died. People who had a goal-directed therapy, the 30% of them died with a very reasonable, it's quite significant, statistical significance actually. Patients with severe sepsis and septic shock were pretty much, but it's kind of all patients were, it's a positive study in all patients. I don't want to go through the critique for that, but this is what we adopted for a long period of time. 2001 to 2014, 13 years later, the process group came about and compared 3 arms actually. They decided to have something very similar to the Manny-Rivers trial versus a protocol based on their own standard therapy in their own hospital versus whatever you guys want to do, go ahead and do it. And then when they looked at the mortality rates, they were pretty much the same. The amount of fluid that was given was pretty much the same. The vasopressor use was pretty much the same. There was nothing different between the 3 groups at pre-randomization. Randomized 6 hours later, when you look at them, they were all different. Obviously, we have more central catheters. We have central venous oximetry. This is all together. There's fluid therapy was different in them, but different statistically, but in reality they were pretty much equivalent when you look at them, except for the last group. When you look at the vasopressor use, it was more towards the goal-directed therapy. WT mean obviously were the Manny-Rivers, and there were more blood transfusions. In parallel, in the UK, PROMIS was America. PROMIS came from the UK. Very similar. They had two arms, early goal-directed therapy versus usual care as they picked it, and there was no difference in mortality. Across the other side, Australia and New Zealand, they did the same thing. No difference in mortality. And then all of a sudden, the Many-Rivers protocol came back and said, oh, it's really, we're doing this for nothing. When you look at the Australian group, there was actually no difference in anybody. When they looked at age differences, patch differences, and basis, there was no difference between anybody. Then somebody, in one of the ATS meetings, put all the trials together with all numbers, and when you look at them, I mean, it looks like the Australians had lesser sick people, but they were more in shock. Lesser sick as far as age, perhaps, as far as comorbidities. But the outcome was the same. And when you look at the amount of fluid that everybody has gotten, it ended up to be pretty much the same. And the biggest critique for PROMIS, ARISE, as well as PROCESS was, you are looking at 13 years later. You mean nobody heard of Many-Rivers? Nobody changed their practice about it? I mean, it's pretty unusual. So everybody believes that these were contaminated with the protocol from Many-Rivers. So it didn't die as a protocol, but it died as far as invasive assessment of the volume status of somebody, because in parallel to this, there was tons of data about saying and maintaining and proving that CVP is not equivalent to a preload to the right ventricle. That was kind of in so many physiologic data, animals as well as humans. So here is where the Surviving Sepsis campaign starts to speak up. After years and years of repeating the same thing, they said that there's no need anymore. Oh, we put something wrong here. Pointer option is a pen. We do not need to monitor central venous pressure anymore. They made it a statement now. And then they said, now the timing of deciding on sepsis is immediately as you triage them through the emergency room. And that's something that we were not doing, to exactly figure out when the time came in. Otherwise, it was pretty much the same. Sorry, guys. Slideshow. From parents, fine. Okay. Next. So what type of fluid? Since fluid therapy seems to be the most important, and people with gray hair always were, surgeons want lactated ringers, medicine wants normal saline, whatever. And people are just like, you don't want to fight with anybody, you say, okay, whatever you want. That was my attitude. Anyway, first let's answer the question of albumin, colloid versus crystalloid. The first study came from 2004, showing again no mortality difference between the two groups. If you were to look at like a sub-analysis of the group, the people who got was in favor of albumin, perhaps a little bit, because it's just crossing one, were the patients with severe sepsis. Remember, this is 2004. The severe sepsis still existed at that time. So perhaps there was some hint, but we don't believe it. Then came the balanced solutions, and there was versus the other colloid, which is the Heta starch that we used it for a long period of time, thinking that we were doing somebody some good. But it was obvious that with this in 2008, ringers versus Heta starch versus the ringers, people who got lactated ringers were better off as far as probability of survival in comparison to people with Heta starch. And perhaps this was one of the death sentences that was put on Heta starch and doesn't exist anymore. Same for low dose versus high dose, they were both as bad. And perhaps the cumulative dose was, the biggest problem was related to kidney impairment as well as death. So the guideline speaks for crystalloids, no more Heta starch. Albumin, think about it, initial fluid challenge has to be with a minimum of 30 milliliters per kilogram of a crystalloid. This has, though the recommendation was there, we have had a very hard time convincing everybody to use it Kidney doesn't work. I need to give them like 5 cc's of water. Heart failure is all over the place. I'm afraid of fluids. Let's just let them drink. It doesn't work on sepsis. Plus, we have the attitude of, I saw a patient, I go write it on the chart. That doesn't work in sepsis. That doesn't work in the ICU. You have to do something. You have to check what you did is right. So yeah, you're going to give 30 cc's per kilogram. It's not going to go in 5 minutes. It's going to go over like a few hours. Yes, it's a bolus, but it's not going to go over 20 minutes. It's usually going between an hour and a half, something like that. In that period, you come back and examine the patient. And as you examine the patient, you decide whether it was adequate, inadequate, complete, or incomplete. And that's something we need to really, really emphasize. And you cannot just keep on writing for boluses. Oh, boluses, blood pressure down, boluses. You have to make a serious assessment of the patient at the bedside with or without ultrasonography. Anyway. What are these fluids that we talk about all the time? This is the kind of the composition of them, and renal folks don't harass me if they are wrong, but I think they are correct. But anyway, plasma is plasma. These are the difference between them, and perhaps the most physiologic is going to be the plasma light if we compare it to plasma. It's a little bit more expensive, but my pharmacy colleagues say, no, it doesn't matter, it's only a few dollars, but we haven't started to use it in the ICU as much as we can. The importance of knowing what this is to know like how much of this stays in the vascular system after you give a bolus. So if you give a bolus of a crystalloid, about 25% of it is going to stay in the vascular space, and the rest is going to ooze out. If you're giving 5%, and that's kind of within, they start oozing out within 4 hours actually. That's why you need to make an assessment on every 4-hour basis really. If you're using albumin, 5% of albumin, whatever you give is going to be in the intravascular space for about 12 to 24 hours. 100% of it stays there. That's why the cardiac surgeons like it very much. It's very predictable. This is the volume I've just given. 25% oxygen, which is not on the slide, and it shouldn't be really used for volume resuscitation because it's unpredictable. It is like whenever you give 25%, about between 300 and 500% of it, because it pulls some of the extracellular fluid into the vascular system, so it's not really predictable. It lasts long, but it's not really predictable. So in the resuscitation ward, we keep it away. SOLVE trial, and I really thank my pharmacy colleagues for creating these slides for me. It was to assess the balance of crystalloid versus saline on patients with, effect of balanced crystalloids versus saline on patient outcome, and the difference was the chloride would be off, and the duration of renal replacement therapy was a bit more in the saline group. Then came the SMART trial, which was a huge trial, actually came from Vanderbilt, that went across units, and this had like 8,000 patients on each arm, and here you have, we discussed this actually in Journal Club, there wasn't really much of a difference except for major kidney function deficit in the group that got the saline, and then when they looked at the composite of death, new renal replacement therapy, and renal impairment, the balanced solution tended to do better in these patients. And by the way, this was studied across all critically ill patients. It didn't really focus on septic individuals, but when you look at the sepsis guys, it was really in favor of the balanced crystalloids. So it's very reasonable to, when you're resuscitating somebody with sepsis, to use either lactated ringers or plasma light. In the presence of my chairman, you have to take blood cultures all the time. And I'm sure you guys know this much better than anybody else in this world. But by the way, if you have an ET tube and sputum is coming out, don't ignore that. It is often that we have blood culture negative cases of pneumonia. And the only way you can figure it out is you have a sputum to figure out what your pathogen is. You don't need a bronchoscopy for that. Sometimes you do, but you don't need it all the time. Sputum is a good thing to collect. In immunosuppressed hosts, do not forget fungal disease. And it's not a bad idea to start getting in the habit of calculating the Candida score to start antifungal therapy earlier in these patients. You have to define the organ that's causing the problem, and you have to do a source control of it. I'm not going to go over the antibiotics. We actually, in the sepsis initiative, the antibiotics stewardship team from our infectious disease division was a big component of that, and they helped us through deciding what's the appropriate antibiotics for us as an institution. Two things: early, broad spectrum, appropriate. Extremely important. If the antibiotics used are inappropriate, mortality rate is going to be high. If you start late, the later you start, the higher the mortality. You reach 6 hours and 10 hours, perhaps these organisms were not this virulent, I don't know, but the state-of-the-art treatment is to initiate antibiotics early. And actually, in the newer guidelines, it's going to come as the 1 hour goal. Like this critical hour, appropriate antibiotics has to be started. You have to identify which the organ. If you have tissue that's necrotic, it has to be debrided. If you have a septic patient who has a device, it needs to be, that is the source of the infection, it has to come out. The drain, debride, device removal, and I forgot what the fourth D is. What's the fourth D? Anyway, this is the antibiotics that we've had. Therefore, the 4 Ds of source control. It's come. Aging is a bad thing. Anyway, with the sepsis initiative, there are multi-teams that we had on board: ID, pharmacy, emergency department, quality, everybody. And we decided, all of us as a group, decided to put the most important antibiotics, not the most important, the most broad antibiotics in the Omnicell at every floor. ER, ICU, Hannah House, whatever it is. You decide if somebody is septic, have an idea of where this is coming from, and one-time dose as a stat dose, they will pick it up from the Omnicell, and they will give it to the patient. Later on, you will think differently. Anything about fluids and antibiotics? Clear? Questions? Good. Now we come to a little bit more, perhaps more exciting for me, more boring for you, is the multimodality approach to vasoconstrictors. Dopamine is a living pressor that will always live. We're trying to kill it, saying that it's a bad drug, but it's not really a bad drug. It didn't do as well as norepinephrine when it came to a direct comparison by the two, but it's kind of still, its badness comes from its side effects if it is not used correctly. Its hazard ratio is a little bit higher than the dopamine, so it always hazard ratio is in favor of the use of norepinephrine rather than dopamine. Remember, dopamine, it depends on the dose, its effect will change. The higher the dose, the more alpha activity it has, but also the more beta activity it has, and you end up with a lot more trouble with it than with norepinephrine. But it still needs to be used for a selected group of people. In a meta-analysis, there was also the favor was towards norepinephrine. How about epinephrine? They're equivalent. They're the same. The epinephrine has a bad view. It's also one of the drugs that at a lower dose it is more tolerable than at a higher dose, because at a higher dose it has a huge alpha and beta activity that causes trouble. But at a low dose, which is less than 0.05, it acts as a cardioprotector actually, and perhaps a reasonable inotrope that people use. But in septic individual, when compared to norepinephrine, it was pretty much equivalent. So currently it's being used as the second line therapy that we add to our care. The third, so if you finish with the catecholamines, next kid on the block is vasopressin. Vasopressin is a natural pressor for us. It has its own receptors in different organs. In sepsis, is usually increased within the first 24 hours. It starts to decrease the second day or the third day. So it should never be used as a first-line therapy. It's always an add-on therapy. And this is the new kid on the block. We really have no idea what to do with it. It's angiotensin 2. Again, too much cellular things for me. It sits on the receptor on the smooth muscle. Eventually, with 700 mechanisms, end up with increasing calcium and contraction of the smooth muscle. It's as simple as that. Clinical trial, ASOS-3. They used it in people who had refractory shock on catecholamines. International, randomized, double-blind, all the good stuff for it's a great drug. We only decreased SOFA. We didn't change mortality. So a little bit of a less organ failure, but still the outcome is death. Now, this is something that we have to wait for over time. There's a lot of strengths and a lot of limitations from the study, obviously, but it's a very expensive drug that they use on a very selected group of people who are probably going to die anyway. So it's hard to tell its benefit. We just have to say, let's stay tuned for it to 2020. I don't know what's going to happen with it. We have not asked for it to be on our formulation as of yet, and I'm not sure we will. Clearly, the sepsis group is going to be in charge of it rather than the cardiac people, because cardiac people will stay away from it, which is the right thing to do, obviously. In the post-hoc analysis, in this group of people, it seems like renal replacement therapy was more in the people who did not receive it. So it was believed to be a kidney protector, though I'm not sure. Of course, we said it's bad. Now, after volume resuscitation, proper volume resuscitation, your pressor friend is norepinephrine. Second line is epinephrine. Third line is a constant dose of vasopressin. There is no data about it increasing in sepsis. Constant dose. Dopamine, don't toss it out. You often get the people who are hypothermic or bradycardic that you need the effect of it to increase, as long as you don't use too huge doses. So far, phenylephrine is not recommended. First of all, it's perhaps the weakest of the pressors. It has a pure alpha effect. We tend to kind of use it when there is a myocardial injury, though it's not really the best thing to do. And please don't think of low-dose dopamine as a renal protector. It affects nothing. It's just a very good diuretic. Much more expensive than Lasix. Not much, actually. It's $4, right? Sorry. Anyway, and the recommendation is still to place an arterial line in case pressors are being used, though you have to remember that with the newer technology, with these tiny little you can get great blood pressure control, and we've been using the flow track actually to determine cardiac outputs from these things in certain people. So think before you put an arterial line. Now we come to some mess. Additional therapies, glucocorticoids are here to stay, but not for all. Insulin, extremely important to use and control blood sugar. Vitamin C is to be determined. Andrea tells me there are 22 trials now going on. Some doctors want to use it, some doctors don't. I don't believe that the data is good enough to say go ahead and use. The study that was published by Merrick, the people who died, who were the control group, shouldn't have died at this rate, given how not very sick they were. So I'm not sure how it's going to pan out. But in case because we're waiting for this multi-center trial results, assuming it's going to be positive, we put a little protocol for people to use if they need to, but not more than that. Steroids, if your pressors are gone, there's no need for it. There's no need to test for ACTH. the time to use steroids is if your pressors 1 or 2 are present and they are on the rise and people are not improving. Clearly, if there's adrenal insufficiency, they need to be used. But in septic individual without known diagnosis of adrenal insufficiency, it needs to be used when 2 pressors are being used. And the minute the pressors are gone, you start to get rid of them. Now, their recommendations ask for a continuous flow. I asked, but how, like maybe a year ago, is there a benefit from a continuous flow versus intermittent dosing that we did? And he didn't think that there was much difference between the two. So if you're protecting lines, perhaps intermittent is as equivalent as long as you don't exceed 200 milligrams a day. We have a glucose protocol. Please use it. If you have 2 readings above 180, insulin drip is your friend. Earlier in the course, please make sure that people don't get hypoglycemic, because if they are hypoglycemic, they are usually in a bad shape. So what are we doing? So about a year ago, they looked at the sepsis data in our institution, and our mortality rates was higher than what's expected for us as a center. Partly, I do believe, is related to poor documentation on our part, that we are working on, but it was a good initiative to have all the disciplines that are involved in it to start this process. What's the scope? The scope is to go over how are we ordering treatment for patients with sepsis. And after much ado, when you look at the order sets that we had, it was 1 for the ED, 1 for the floor. ICU had absolutely nothing. And after much discussion, we agreed that the first thing that will come out is all of them will come out, and we will put a 3-hour, first 3 hours of care, whether it's in the ED, whether it's on the floor, it doesn't matter. And that's the first order set that is currently available to all. On it, antibiotics are there, fluids are there, whatever cultures you need to do, and I ask you to please use it. If you don't, you're going to forget few things. So please go for it. A lot of it are automatically checked. You just have to choose the organ that is giving you the trouble, and it will highlight the antibiotics that you need to choose. And those are present on the floors. Please don't write the order and go. Go talk to the nurse at the bedside. Tell her, these antibiotics I ordered for, they are right there. Can you please hang them? The earlier we hang them, the better we're going to be. In the making is after the first 3 hours, which is going to be on the floor, and then later on it will be in the ICU. And actually, they are going to be worked on in parallel. Artificial intelligence is starting all over the place. Soon, none of us will work. We'll just sit there and play with our computers. Actually, might not be a bad idea to play on the computer all the time. But anyway, so several centers have actually started this with very good results. How they do it is they get all the data from people who have sepsis and get historic data and all the demographics, and they're like thousands and thousands of data points to get the computer to decide what's wrong with the patient and how to treat them. This is commercially available now, and I believe UH started to get into it, and Dr. Sunshine has got us a contract with Javon, whatever it is, and they're currently in the process of putting it together, that is the data together. The other thing that we're working on, and actually this is stay tuned, most likely it's going to be available in 2020. Then we're working on the early warning signs. N stands for national, but it's not fair because we're adopting this from the UK. So I'm not sure, we need another letter in order to make it catchy, but the literature refers to it as news. I will come to it very shortly. Prevention is very important, you guys. If you don't need a center line, take it out. If you don't need a Foley, take it out. And that's another initiative that's working in parallel to decrease the infection rates. BioPatch came back. The way we have a series of teaching for residents and fellows on how to put center lines in order to decrease infections. And there's a checklist. The nurse is at the bedside who's going to be attending these is empowered to tell any doctor who didn't go through the universal sterile technique, stop. And they don't have to say please. You just have to stop until you go on doing your business. And with this status that we have, I'm proud to say that on assignment 7, the combination of MICU and heart failure, our last central line infection has been, 250 days or something like that. So we're pretty well. But keep it up, guys. Keep it up. And we have this new thing, take the Foley out for women. They devised this wicker thing that you suction rather than use Foley. And lastly, which has been the first thing in our education, has been in the sepsis tri-leaflet that Andrea is fantastic at keeping it up to date with the help of everybody else as well. And it's still available. It's your great guide for all what I just said over the past 50 minutes. News I will tell you about, it is a scoring system that looks at the people's respiratory rate, oxygenation, whether they are oxygenation with high PCO2 or not, whether they are on oxygen or not, blood pressure, heart rate, and their mental status. And we have to decide whether to use the British way of looking at mental status or us, as well as temperature. And whatever the score is, it comes as anything greater than 7, they are seriously ill and they should be in the ICU. If it's between 5 and 6, low threshold for ICU. When the score is determined by one organ, it means it's drastically abnormal, that one has to be on the alert for. And then the scoring system, if less than 4, usually they stay on the ward with the help of the primary team or with the help of the code white, or they're going to refer to it now as rapid response team, I think, in the near future. Now, this is what I'm working on, which is to decide what people will do in the hospital depending on the score, and it's work in progress, but in principle should be going to IT very shortly. It's a logic. It's to determine the logic of, you determine the score, what's your action plan, and your action plan would be contact the primary team versus code wide versus nothing versus whatever. And it gets increased and changed from a different level to another. This is in a graphic form, but this will be coded in the computer. So when you go to the morning, whoever the nurse is at the bedside will get an alert on what the new score is. And according to that score, will have to determine, like he or she have to determine whether the plan stays as such, there's nothing to worry about, there's a change, let me call the primary service, see if they're expecting it or not, and if it's really bad and they cannot handle it, we'll go ahead, expand to code white or ICU or whatever it is. But that is in the process, and that's happening right now, like it's being coded in the EMR, and hopefully by 2020 it will be rocketing. All what I just said can be summarized on this picture. Literally, this is a great picture, I think. Sepsis is a multi-organ system abnormality. It is complicated when you think of them all at the same time. When you think of them in priority and be systematic at approaching one at a time, making sure that the primary source is under control, success will happen. With that, I think I end from AUB Beirut. Okay, thank you.
So, Rana, always tremendous and passionate. A couple points. One is the more recent theory of corticosteroids. This is the adrenal study. They use mineral corticosteroids as well. You did not mention that. Secondly, a recent study about early initiation of renal replacement therapy. We have an expert with us.
Ask him the question.
And I'm visiting us, Dr. Trinivas from after you answer some of these questions.
The story of Spear, I wish Baha was here because he would have answered it more eloquently. We are biased because of Baha. Baha knows adrenal disease like unbelievably well. And when you look back at the study that was used, the study that used the dose of mineralocorticoid that they used is minute in comparison to what hydrocortisone did. So it didn't really make any sense that they used it. But the person who did it, like actually the group that did it, the French group, is a little bit biased also in how they address their disease. They started off actually, and part of their biggest problem is they don't share all their data. And their initial work, they say, oh, steroids like help everybody out. A lot of the patients in that study were sedated with etomidate, which can act as adrenal paralyzer for a period of time. That's why they had this huge outcome. Corticus did not show any benefit, and that's why we're kind of not using it at all. As far as renal replacement therapy early, I would like to defer to you. I can.
I'm actually going to punt because I feel that we use it by the seat of pants. But I have a question for you on how you use streaming data, because in ICU, you have a richness of data on vital signs, cutaneous perfusion, even your waveforms of the various hemodynamic measurements. And in the old days, we had to use invasive measures.
Right.
And we all carry a stethoscope, which I think does little less than spread infection. And I'm just, wondering if the time has come where we actually have continuous echocardiographic monitoring with, artificial intelligence actually applied to how those things change. Because you talked about JVON, but JVON is to some extent static because it's measurements from other people that don't necessarily fit the reality of what you're dealing with on a day-to-day basis. And there may be a huge opportunity actually to look at what we do with data in the setting.
Well, actually, I tell you what we do, because currently we have the experts at it, and that's Frank Giacono have a huge research project in septic individuals on looking at variability of hemodynamic, respiratory, as well as neural variation in patients with sepsis in the ICU currently. So what he does is he doesn't look at individual data points. He actually gets the waveforms that he has, and they and Frank, if you can elaborate on it, they go through a mathematical modeling in order to figure out what's happening.
No, we can talk about it afterwards, but we are actively collecting data in the ICU with patients with sepsis and for sepsis, and that data does include waveform data, including cardiac patterning, breathing patterning, arterial blood pressure collected at multiple samples per second, and we're hoping to build a large data set from which we can then compare to our animal models of sepsis and learn to better understand the pathophysiology and also more early identification of patients found to tip from infection.
I think the other big thing is most of these papers that since we're okay. So most of the papers quoted talk about means, and they put the standard deviation as an afterthought, whereas we're finding out more and more, especially as we model things like when kidneys fail, it's more the variability around your measurements and the loss of autoregulation that basically signifies somebody who's going to fail. And that's exactly. I mean, we're preaching to each other, I guess, but that's kind of where I think the opportunity is.
Absolutely.
Because I think everything, like you're throwing out the central line catheter, central venous catheter, I think we need to, for measurement of hemodynamics, I think we need to throw out stethoscopes. And I think we have to actually think about, because it's more of a ritual, and I think we can monitor everything on an ongoing basis using sensors and proper imaging.
That's actually what's happening right now with these two of them. It's difficult. So that what's happening now, as far as monitoring going, as you know, I mean, monitoring devices that are currently available have a lot of limitations in non-ventilated patients. even in the ventilated patients, the way we monitor people as far as hemodynamics go is very crude, because we have to put people on much higher tidal volumes than they are. And the people who are spontaneously breathing, the data is extremely unhelpful. Perhaps the one thing that's helpful is continuous echocardiographic evidence. And when you look at the left ventricular function, when you calculate the VTI, with the velocity, transit time, what do you call it? VTI is what they refer to. So when you're looking at, where's the cardiologist when I want them? Thank you. Velocity times interval. So you look at the velocity of the jet as it exits the aorta, as it exits the aortic valve, and you plot it, and it comes like this. Not sure. So it comes like this. Every heartbeat comes like this. You calculate this area, and this correlates to the stroke volume. And when you're using leg raise, like passive leg raise or a fluid or whatever, you monitor this. And as long as keep on increasing, you'll be able to do it. We have the capacity to do it through a transesophageal probe, but it's not yet, the technology is not yet find the place and stay continuous. It's not that way. It is intermittent, like you have to look at it in different intermittent ways. So the techniques are evolving. Echo is I think it's going to be attached to the stethoscope rather than throw the stethoscope, make it a tiny little device. Maybe they will implant it at birth too. I have no idea. But that's what's going to happen.
The hour is late. So thank you as always for a fantastic. We can probably go on for half an hour, but for a fantastic talk. And